a radius fracture. Shows neurovascularly intact, closed reduced and placed into a sugar tongue splint. This next case was previously presented. I'll just be presenting some follow-up. So he's a 58-year-old male, status post conveyor belt injury with multiple injuries to the upper extremity. Specifically, we'll be focusing on the right thumb proximal phalanx fracture and CMC dislocation. Initially, it was taken for closed reduction percutaneous pinning. In August, he underwent a removal of hardware and was subsequently noted to go on to a non-union. So the patient was taken to the operating room for takedown of non-union, open reduction, internal fixation, bone grafting, the proximal phalanx. Next patient is a 78-year-old female presenting after a ground level fall, the right proximal humerus fracture. Patient was neurovascularly intact given the degree of displacement. Patient was taken to the operating room for a closed reduction and percutaneous pinning. Surprisingly, yeah, with some like abduction and traction. Yeah. My understanding was that was usually the reduction technique, since a lot of times the the head will go into almost like an abduction type pattern. You try to abduct the rest of the arm to match the angulation of the humeral head and adduction. Okay. Okay. They are.
Is there literature to say displaced proximal humerus fractures? Oh, what's the better outcome for them? What kind of fixation? Because you don't see this typically done, right? Percutaneous pinning.
Yeah, I mean, I'm not sure of any specific literature that compares this to, like, let's say, like an open reduction or internal fixation, but the theoretical advantage is that you have less soft tissue damage and decreased risk of like AVN. There was some literature to suggest that it was about like 4% risk of AVN with this type of procedure versus an open procedure, which is around like 16%. In terms of like long-term outcomes, I'm not aware of any specific studies that look at that. Next patient is a 55-year-old female after a ground level fall or fall down several steps with a right ankle bimalleolar fracture. She was provisionally closed, reduced, and splinted, taken to the operating room for an open reduction, internal fixation. Thank you.
Morning. First case is an 11-month-old female status post fall from a bed with a right distal both bone forearm fracture. She's grossly neurovascularly intact and placed into a long arm bivalve cast. Next case is a 13-year-old male status post fall from a fence. The left both bone forearm fracture. He was neurovascularly intact, closed reduced, and placed into a sugar tongue splint. Next patient is a 9-year-old female status post fall from a swing. The right proximal humerus fracture. She was neurovascularly intact, made non-weight bearing sling. This is a 5-year-old male with type 3 OI who presents status post fall with a right acute on chronic tibial shaft fracture. He was neurovascularly intact and placed into a long leg bivalve cast. This is a 90-year-old male status post mechanical fall with a left proximal humerus fracture, neurovascularly intact and made non-weight bearing sling.
Can you go back if you're going to mention type 3 OI? You might as well go ahead and tell us the different types.
Sure. So
you know those?
Huh?
Yeah. Just give us a rundown on OI.
Yeah. So OI is a disorder of collagen. It can be either quantitative or qualitative. Type 3 is the most severe survivable form. It is a qualitative defect in collagen. Type 1 is the most common, is also qualitative. Type 2 is lethal in uro. And 4 is also qualitative, and there's 5 and 6 as well as several others.
Okay.
Which
And
one
then-
has the blue sclera?
I know 1 and 2 have the blue sclera, 3 does not.
So there's only
Four
four
usually
types of
does.
OI. Is there only 4 types of OI?
No, there's 7, I believe.
Mm.
At least.
There's
At least.
many more than that. Okay, I
Okay.
think there's up to about 12 now, but 98% are in the first 4. So those are the ones you need to know.
I don't expect you to know, how to manage this going forward, and
Yeah.
I don't know what the angles are, so I'm happy that Dr. Bowe is on the call here.
Yeah.
But at what point do you think this needs surgical intervention, and how do you think it should be managed?
So he has long bone deformities of all of his lower extremities, both femurs and both bilateral tibias. You'd like to kind of prolong his conservative management as long as possible. There's ways you can treat these with osteotomies and growing rods or non-growing rods. I'm not entirely sure of how I would manage this surgically or go about it.
How many fractures does he have?
He's had multiple fractures of both of his femurs and both of his tibias. This right tibia has been fractured 3 times. And
Is
once.
deformity more or not?
The deformity is similar.
Mhm. So why would you like to wait as long as you can?
These kids, when they get older, they tend to break their bones less. I think anytime you do an operation on a kid with this many deformities, they carry a lot of risks. And the fact that he has deformities of all of his long bones, if you did surgery on one, it could put extra stress on the other, and then you're kind of chasing different limb lengths and things like that.
Well, I think the real reason to wait is that, you have more bone stock to work with. There are certainly, various rods that you can use that hopefully will expand as the child grows, but there's problems with no matter which rod you use. The Fazier-Duval rod is the one that's probably most commonly used today, but years ago it was the Bailey-Dubois expandable rod, and then a lot of people have just used rush rods. But if you can get them to, a reasonable age, it just means that you can put a larger rod in. It's less likely to break, and it's less likely to have need a revision. So usually if the deformity is increasing and the fracture is recurring more often, then, that's usually when you are your hand is forced. Is he braced?
He was braced at one point, but I don't know that he uses his braces anymore.
Yeah. These kids usually need bracing, and it'll get them to an older age, but how bad are his other extremities?
Pretty similar, at least clinically to me. The x-rays I looked at, both tibias are very bowed, so are the femurs. I know he's had bilateral femur fractures in the past, but the right tibia has been the one in the last year that's caused the most problem. He was only a couple weeks out of his prior cast when this happened. So
sounds like he's looking for something relatively soon. Usually there's one extremity that's more problematic, and that's the one that you will usually attack first, but not an easy problem. Is he on any bisphosphonates?
I'm not sure. Based on some of the notes, at one point he was getting bisphosphonate therapy, but I'm not sure currently.
So there's advantages to bisphosphonates, but if you're going to do an osteotomy They probably need to be off the bisphosphonates for probably, some people say 3 months, some people say at least 6 weeks for bone healing.
This is an 83-year-old female that's supposed to fall down the steps with the right LC1 pelvis. Of note, she had a left hip fracture treated with cannulated screws roughly 10 years prior. Her CT scan, she was made protected weight bearing and sent out on DVT prophylaxis.
Good morning. First case is a 70-year-old female, right hand dominant, ground level fall with this right distal radius fracture. She's closed reduced, placed into a sugar tongue splint. Next is an 89-year-old female, also right hand dominant, status post to ground level fall with this right distal radius fracture. She's closed reduced, placed into a sugar tongue splint. Next is a 74-year-old female, status post fall downstairs with this left patella fracture. The primary team got a CT scan of her knee showing this non-displaced patella fracture. She was able to straight leg raise. She was given a new mobilizer and midweight bearing in extension. Next is a 90-year-old female, status post ground level fall with this right hip intertroch fracture. She's admitted to the medical team, medically optimized and taken for a right hip IM nail. Following day, she's made weight bearing as tolerated. Next is a 74-year-old male, status post ground level fall with this right ankle trimal fracture. Submitted to the medical cert. He was provisionally closed, reduced, and splinted, admitted to the medical service, medically optimized, and taken for right ankle ORIF. Following day. Thank you.
Morning. First patient is a 13-year-old male who fell and sustained this right distal both bone forearm fracture. He was closed, reduced, and placed into a sugar tongue splint. Next patient is a 4-year-old female who fell playing tag outside, who sustained this left non-displaced tibial shaft fracture. She was placed into a long leg cast. Last patient is a 44-year-old female who smashed her small finger with a car door and sustained this left small finger distal phalanx fracture. There's no nail bed injury or laceration. Of note, she does have this middle phalanx and chondroma. She was just placed in a bulky dressing and
Has she known about the enchondroma?
sorry, what was that, Dr. Bo?
Has she known about the enchondroma?
No, it was incidental. She had no idea.
Anna saved her life.
Hmm.
Good morning. It's the wrong date. Sorry. This is a 15-year-old male who was fell to the ground during a tackle in a football game, seeing this right radial shaft fracture. It's closed, reduced, and placed into a sugar tongue splint. Watch it very closely. Definitely very concerned that it's going to redisplace and would have a low threshold to fix it later if it does.
Was his
Yeah.
DRG okay?
Yeah, it was okay. There's a 13-year-old male Sassafras fall playing basketball, saying this minimally angulated left distal radius fracture. He was closed, reduced, and placed into a sugar tongue splint. There's a 10-year-old female status post fall. She jumped during ice skating and sustained this left tibia and fibula shaft fracture. She was placed into a long leg bivalve cast. An 87-year-old female who fell at her nursing home and has this right proximal humerus fracture. She was neurovascular intact and was placed into a sling. Is a 52-year-old male status post fall with a left proximal humerus fracture. It's also placed into a sling. It's a 59-year-old female, fell down the stairs, has a non-displaced radial head fracture, no blocks to motion, was placed into a sling, advised to begin early range of motion. It's a 28-year-old male who was trying to protect another bystander from a pit bull and sustained this open right distal ulna fracture, as well as a small finger metacarpal base fracture managed by the plastics team. He was initially taken for an I&D in the emergency department, and the following day, after given antibiotics, was taken for a right ulna I&D and ORIF. He was placed on unison for 48 hours, received rabies immunoglobulin, and was discharged without any wound complications at the time.
So you don't think that would have healed by itself?
I'm sorry.
That wouldn't have healed by itself?
I think it could slowly, but we felt that this would be a faster time to union and function of the wrist. And we were in the operating room for the I&D and it was mostly exposed already.
What's the bacteria? What's the bacteria you're protecting against? Is there a pit bull bite?
So the most common for dogs is Pastorella.
Mhm.
And Pastorella is even more common with cat bites.
Uh-huh.
So I was going to mention that my experience with distal ulna fractures, and particularly those that are open or bite wounds, is that they take a really, really long time to heal. The non-union, I think, is pretty high with that, and functionally those go to become very problematic if you don't fix them. So I have a predilection for wanting to fix these. There's frequently hardware problems, so you have to be prepared to take the hardware out. Particularly with the open wounds, there's not a whole lot of bone there to have to go back and bone graft. It's not uncommon. It's a bad trauma to the soft tissues as well, and so they're problematic. Did you examine the distal radial joint on this one when you were done?
Yeah, he was stable and had a full range of motion and prone supination there. This is a 57-year-old female, works at a group home and was bit by one of the residents there. Sustained this left small finger tip amputation. She was given appropriate antibiosis and was unfortunately discharged prior to her post-Ronjur films, but just took down a few millimeters there, so it was covered by soft tissue.
What's the appropriate
So-
antibiosis?
She was given unison in the emergency department and then discharged with augmentin.
For what bacteria in a human bite?
Canella. This is a 75-year-old male status post fall with a left femoral neck fracture. He had a history of a renal transplant and is on tacrolimus and chronic steroids, as well as a prior stroke without any residuals. He went for a left hip hemiarthroplasty. No. His renal function is actually pretty good still. There's a 49-year-old male who was a pedestrian struck with the right fibular head avulsion fracture. He was very swollen, but his exam was stable, and he was placed into a neomobilizer for comfort, and made weight bearing as tolerated.
And his exam is stable.
He did not have any laxity to varus or valgus. He had a negative Lockman posterior jaw. He did have joint line tenderness on the medial and lateral aspects, but otherwise had a full range of motion without any instability. I think it's just the angle.
Is there a significant knee effusion on your exam?
Yep.
I think it's from the fibula being injured.
No, I wouldn't be surprised if he has meniscal injuries. I don't know exactly where the impact was. Yeah, he had a lot of imaging done on the rest of his body as well. That was negative. This was his only injury. He was actually discharged after presenting and came back 6 days later, and this was found. This is a 78-year-old female who fell down a few steps and sustained a left fibular neck fracture. She also had a stable knee exam and did not have a hemarthrosis. Her ankle was, I don't have the images in here, but there was no ankle injury. She was given a knee immobilizer and made weight bearing accelerated.
What injury do you worry about with the fibular neck?
You worry about Mason-Newt fracture. And it could also be associated with meniscal injuries or other ligamentous injuries.
Maybe tibial plateau, the other thing you have to
Plateau,
worry about.
The 27-year-old male who had a couple of drinks and sustained a fall with a left ankle Weber B fracture that was stress negative. It's placed into a posterior splint for comfort. There's a 27-year-old male who sustained a fall and twisted his foot with a right fifth metatarsal shaft fracture. He was placed into a posterior splint. I would definitely consider it. It's pretty displaced. Yeah, I think it would just take longer.
Shaft fractures, I think it should always take longer than metaphyseal fractures, but those big lung oblique ones, those big lung oblique ones don't seem to take that long. They don't result in a lot of deformity, and they'll have foot pain for a little while, but those I don't fix typically. They look terrible, but they heal okay.
Thank you.
Good morning. First patient is a 69-year-old male who was on a ladder, who fell, sustained a right closed pilon fracture and left closed calc fracture. These are images of his pilon. Calc. Ladder, yeah. He's doing plain gutters for leaves. These are images of his pilon fracture. He did have some significant swelling of his pilon, some blistering. This imaging of his calc. These are all acutely by an outside hospital. Taken for an X-fix of his right pilon and placed into a posterior splint for his calc fracture. He remained in the hospital for a week and his swelling had subsided on his right pilon. So he was taken to the operating room for RAF. Yeah, I think there's some like disposition issues because he had bilateral extremity injuries and joint placement. And then we were monitoring his skin, and it improves to the point where he could undergo surgery, sort of procedure.
What approach did you use?
Next patient's a 51-year-old female, status post fall, presented with the right femoral neck fracture. Of note, she has a significant psychiatric history, schizophrenia, bipolar. She was taken for the operation for right hemitransverse. So the calcaneus, we're gonna wait till the Swan resolves and then take another X-ray and see, what it looks like. Initially it's comminuted, polar angle is basically 0. But he is also 69 as well, so the outcomes are similar in patients over 50. It'll just be a discussion with the patient, about what the surgery. It shows, like kind of like the combination in that posterior facet, and yeah. Oh, it's like 20 to 40.
What's his Sanders classification?
Last patient is a 63-year-old female, status post fall, a couple steps, had this right closed, trimal ankle fracture. She was close reduced, and a CAT scan was obtained to better delineate her injury pattern. It didn't really probably change what we did, but I think it was good just to get a better idea of what was going on in the posterior mal, because at least on the initial injury film, there might have been like some impaction, and we didn't get a good idea of how much involvement there was. We did ORIF. We didn't address it. It looked anatomic for the case, but you could have, if you wanted to, I think it's pretty reasonable to do a posterior lateral approach, addressed the fibula, address all 3 mals. I think it's pretty. Doing that procedure, you get the best stability biomechanically. But it's just the preference of the surgeon is to not do it just based on how it looked.
And it's the, just check that the audience is included.
You guys hear me? Oh no, it's Zoom.
Can you hear us?
Oh really?
I guess then can't hear us.
Oh, okay, sorry. Okay.
Say that again. We didn't hear you.
Can you hear us now?
Yeah, I can hear you now. Yep.
For the calc, what was the Sanders classification?
It's a 4. So it's comminuted in the widest part of the posterior facet.
So what's a preferred treatment for a Sanders 4?
So you could do an ORIF with the arthrodesis.
And what happens if you leave it alone and do the when he goes on to arthritis, do the arthrodesis then?
Yeah, so the highest complication for these fractures is that subtalar arthritis. So be symptomatic, and you also need to do an arthrodesis procedure then.
The arthrodesis is simpler and has better outcomes if you restore the anatomy of it, right? Because if it's compressed, crushed, and all your angles are off, and then even if it's in a year or 2, then you're doing a lot of extra work to correct the problem, even if you're doing the arthrodesis at a later time.
Yep.
Dan, the 51-year-old who received a hemi for that femoral neck fracture, is that the standard of care?
No. So we thought about doing total versus a hemi. There's good literature saying that some strong meta-analyses that show long-term that functionally a total will be better than a hemi. There actually was like a study published in 2019. It's called like the health trial, where they randomized patients to hemis and totals who were 15 and older. At least in their analysis, there wasn't a difference clinically between either group. Additionally, they found like a double rate of dislocation with the total, but that was just only looking at 2 years. it's at like the cusp of, we consider maybe fixing it. If this person was younger, I think you would try to restore that anatomically and see how it did. But, it's kind of at that tweener part, 51. And, I think what really drove our decision was just her significant psychiatric history.
You said she's bipolar, right? I mean, how bad was she? She did not have a long life expectancy. She's going to be psychotic in your office with arthritis from her hemi. Was she not going to be compliant? What's the deal?
Yeah, we're just, in addition to that, we weren't sure how well controlled she was, how reliable she was, whether she would be able to follow up with any sort of posterior precautions. Additionally, she had some sores on her body as well, missing teeth. It just wasn't, a good situation.
Are there approaches to totals that are better than others for your concern of dislocation?
You could do like a direct lateral, anterolateral, direct anterior. Those are also been shown to have decreased dislocation rates compared to just posterior. But she also had, anterior like skin sores and like Canada, all that kind of stuff. This wasn't. If she does follow up and has hip pain, proves that she's reliable, I think dealing with revising a hemi to a total is a better operation than, dealing with the dislocating hemi.
To make sure she has Ken Swan's card.
Ken Swan's card, okay, Dr. Leddy.
Did you say revising a hemi has better outcomes than a what?
Oh, if you had to pick, between an acute dislocating hemi or revising someone from a hemi to a total after they've proven to be reliable and,
Why is your hemi dislocating? Hemi is one of the most stable ones, better than total hip. So if you have a hemi that's dislocated and you're screwed.
Sorry, I meant dislocating total. I misspoke.
Okay. But that can be better optimized with the dependent approach. Because what approach did you use for your hemi?
We did a posterior, but we couldn't do the other ones based on what her skin condition looked like anteriorly.
Okay. So when you have to do the total, what approach are you going to use?
Do posterior, go back the same way. Went in.
Which will have the same. So a secondly operated on hip total, do those do better with dislocations than primary?
So a revision would carry a higher dislocation than a primary for sure. But there's a lot of different factors that you're considering. But if this person has been shown to be reliable and you respect the soft tissue during your revision, get a good capsular repair afterwards, I think you sleep more comfortable at night. Yeah, she could possibly live. Yeah, it's possible. Yeah. Yeah. Well, I saw tissue there.
Good morning. Patient's 7-year-old male, status was a fall of a monkey bar, is presented with a right posterolateral extension type 3 supracondylar humerus fracture. He was neurovascularly intact. He did have a brachialis pucker sign with some anterior skin dimpling in the antecubital fossa. He was taken that same evening for a closed reduction in percutaneous pain. I probably expect anterior interosseous nerve with an extension type, most likely. It's most common. That's all. Thank you.
Morning. First patient is the 22-year-old male. This was the gentleman who has a history of Down syndrome, who's being attacked by that pit bull when the other gentleman intervened. He sustained this both bone forearm crush injury. It was open with multiple puncture wounds. He was washed out in the trauma bay and then taken to the OR that night for a radius and ulna I&D and ORF. He did receive antibiotics for 48 hours with Unison. This next
What was the
42
neurovascular exam?
His neurovascular exam was intact. It's absolutely fine.
And in tendons?
Tendons were all fine as well. He mostly had more of a crush and just several puncture wounds. The gentleman that Todd had presented had much larger lacerations. Next is a 42-year-old gentleman who is involved in MVC. He's a rear seat passenger with this right scapula, right proximal humerus fracture dislocation, and a left tibial plateau fracture. CAT scan was obtained by the trauma team showing this humeral head dislocation. He was neurovascularly intact. He was taken to the OR the following day for right shoulder hemiarthroplasty. And then we also did an ORF of the the lesser tuberosity was still attached to subscap. And so we were able to attach it anatomically back and use this small, there's a 2O plate and augmented that with some sutures. And then his tibial plateau fracture. CAT scan better delineate the fracture pattern. It was taken the same day for tibial plateau ORF. Next was a 66-year-old male who's also involved in MVC, the right posterior wall acetabular fracture, tibial plateau fracture, and then the left distal radius fracture. CAT scan better delineate this posterior wall acetabulum. It's taken for tibial plateau. Acetabulum ORF with spring plates is tibial plateau. Better delineated with CAT scan. It was initially X-fixed and taken in a delayed fashion for this ORF. And then his distal radius fracture was taken on the same day as the tibial plateau for an ORF with this hook plate. Next is a 42-year-old gentleman involved in MVC with a right acetabulum fracture. Better delineated on CT showing this posterior wall hemitransverse fracture pattern. It's taken for an posterior wall hemi and acetabulum ORF dual plating. Next is 87-year-old female sustained a trip and fall. This left intracanteric hip fracture. It's taken for a left hip IM nail. This lady was under 5 feet tall. This nail looks huge. It's actually a size 10 now. Next is a 73-year-old female sustained a trip and fall down 2 steps. The right femoral neck fracture. It's taken for a right hip hemiarthroplasty. Next is a 74-year-old female who had this hemiarthroplasty done in July at an outside facility. Has been ambulating at home with a 4-point cane. Tripped in her hallway going to the bathroom in the middle of the night, sustained this right Vancouver C periprosthetic femur fracture. Was taken for a right femur ORF with cabling. Next is a 22-year-old male status was dirt bike injury with his right femoral femur and open distal radius ulna shaft, distal radius and ulna fracture. Was taken to the OR for right femur IM nail. His distal radius showing this significantly comminuted distal radius fracture. Taken for a distal radius ORF. Ulna, we felt it was significantly comminuted and chose to just leave it as it was, and we did put him in a sugar tongue splint. I think we were satisfied with the reduction of the distal radius. We did establish some height back. The plate was not exactly where we wanted it. However, we were happy with the reduction at that time, so we chose not to move the plate.
So Andrew, when you see this guy 2 months later, which maneuver do you think will be the most limited for him with his wrist?
What is the rest of that on the lateral post-op X-ray?
Sorry, for Dr. Katt, I think he's probably gonna be more eliminated by supination. And
Yeah,
what was
I
that,
think-
Dr. Pushilin? I couldn't.
I was just going to say, I agree. I mean, it doesn't look like that DRUJ looks, you know, anatomic, and that ulnar head looks to be a little bit translated. And I think Dr. Pushilin was asking, what's all that bone that we see on the lateral view dorsally?
I think that's it's probably a portion of the ulnar styloid.
So it's not close to where it's supposed to be. So he's gonna have, like mentioned, he's gonna have problems at 22 years old, right?
Yes, he was 22. Yeah. I agree. Next is 16 plus 11-year-old male. He was a football lineman. He was chop blocked, sustained the Salter Harris 4 distal femur fracture. He was taken to the OR for a distal femur ORIF locking plate. We are treating him as an adult with no growth left. So we chose to plate across the physis. Next, a 59-year-old female.
What was your exposure for that?
We went lateral just as if we were doing a distal femur fracture. We elevated vastus lateralis and slid the plate up.
Okay. How about if you treat him as an adult, what's your preferred treatment for intra-articular fractures? What are the principles?
I would still lag across that fracture site. We did initially lag across the interarticular split, compress down a little bit, and then swap that screw out later for a locking screw. And then we had, in this case, we did have cortical screws, but you could also use locking screws proximally.
Did you look at the joint when you did that or no?
We did not look in the joint. No, actually, we were able to visualize across the joint and feel it compress. Yeah. You could stick a finger into the joint, you'd feel it compressed. There was no step off. We're happy with the reduction.
You leave that plate in or take it out?
So I think you could argue to leave it in your treatment as an adult, but I believe when discussing with the attending at the time, he is only 16, he would consider taking it out. There's no reason you couldn't leave it in. And his physes are fairly closed. And even if he was to have a leg length discrepancy, it'd probably be under a centimeter.
He's going to play football next year.
Consider taking it out. So next is a 59-year-old female, significant morbid obesity and BMI over 60, sustained a trip and fall with a left distal femur fracture. Was taken to the OR for a nail plate combo. And then we did lock the plate, the plate through the nail. Next is she did not. Amazingly enough. This is a 46-year-old gentleman who's assaulted, sustained this right distal femur fracture. He's a past history of knee injury, although he was unable to be more specific. It appears just based on the CAT scan and his x-rays that he had a distal femur fracture and plateau fracture in the past. He was provisionally X-fixed as the first day we took him to the operating room. He was significantly swollen, was having some symptoms of compartment syndrome. We did a fasciotomy on him. And then took him delayed faction for this distal femur ORIF.
Fasciotomy of what, the leg or the thigh?
Thigh. And when we did the muscle exploded out of the compartment. It was critical. That's it. Thank you.